Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I am really pleased to be here to give the last of the CROI updates from this year's CROI conference. I'm going to be focusing on HIV CoInfections. I know you heard a lot of great HIV content from CROI about treatment and prevention. I'm going to be focusing on the non-HIV explicit content of CROI, or as I like to say, putting the OI in CROI. These are my disclosures and the statement from AETC that race is not race creates and perpetuates health disparities. That is how we will frame any discussions in this. So for this talk, I'm going to highlight abstracts and symposium presentations from CROI that focused on TB, COVID-19, and Hep C, and I'll try to focus on the interaction between each of these and HIV, since this is the HIV Echo. I'll talk about one abstract in some detail and then do a lightning round with some brief summaries of other exciting abstracts and data that come out on each of these topics. So let's dive right in. Tuberculosis, always great content at CROI, since TB does remain the leading cause of death among people living with HIV. I'm glad we get to focus on this. And there's a lot of focus on both TB treatment and prevention. So the abstract that I'm going to present was given by Anthony Podney from University of Nebraska. And this is a study looking at the pharmacokinetics of dolutegravir given with short course TB prevention therapy. So a few years ago, the Brief TB paper study showed that a 1-month daily regimen of isoniazid and rifapentine, or 1-HP, was non-inferior to 9 months of isoniazid to prevent TB in people living with HIV. To prevent TB, many of the participants were living with HIV, and all of the people living with HIV were on efavirenz-based ART because of the significant drug-drug interactions between rifapentine and integrase inhibitors. So as you may know, Biktarvy is completely off the table for giving with rifapentine, all of rifamycin, so rifampin for TB treatment or rifapentine for treatment or prevention. And we know that rifapentine metabolism or rifampin metabolism can decrease dolutegravir levels. So currently the recommendation for TB treatment given with rifampin is to give BID dolutegravir in people taking a dolutegravir-based antiretroviral regimen. The Dolphin study a few years ago looked at the weekly TB preventive therapy regimen using isoniazid and rifampin weekly, given with daily dolutegravir, and that found that there was no decrease in virologic suppression among people taking daily dolutegravir antiretroviral regimens, and they found the mean trough of dolutegravir was around 550 nanograms per mil. That remained totally therapeutic and effective for 3-HP weekly TB preventive therapy. So now the question is, what happens if you're giving the daily 1-HP regimen with dolutegravir? And to start the study, they looked at a BID dolutegravir dose because there is no data and there's some concern that daily dolutegravir would be not therapeutic and would not suppress viral loads. So the first stage of the study was looking at the pharmacokinetics of dolutegravir along with BID dolutegravir along with 1-HP, with the plan to advance to a study of daily dolutegravir if this was successful. So the design for the study was enrolling 36 adults with HIV, all of whom are virologically suppressed at enrollment on a dolutegravir-based regimen. No one was taking TAF because there's also a rifapentine interaction with TAF. No one could be breastfeeding or pregnant. And at the conference, data on the first 25 participants were presented. So folks were taking their usually a dolutegravir TDF FTC regimen, some were TLD, and then they would be started on the 1-HP, which is 600 milligrams of rifapentine plus isoniazid. At the time they started the 1-HP, dolutegravir dose was increased to BID, and then they underwent intensive pharmacokinetic sampling and viral load measurements at the end of the 1 month and then at a follow-up period. So what did they find? The researchers used a minimum trough acceptability for dolutegravir to be 158 nanograms per mil. So that was kind of the lowest threshold that would be considered potentially acceptable based on prior studies that had been done with dolutegravir. And this graph shows the PK of dolutegravir. So you can see it at baseline. This is before people started the TB preventive therapy regimen. Dolutegravir levels with daily dolutegravir were a little bit more than 1,000 nanograms per mil. And then the first week, now on BID dolutegravir and TB preventive therapy, dolutegravir levels actually increased and then came down over time over the 4 weeks of the TB preventive therapy regimen, but remained all within approximately the level of the baseline dolutegravir levels, with a few outliers falling lower, but no one had levels that reached the low threshold of acceptability. Viral loads were measured at the end of the 1 month period. One participant had an HIV viral load that was detectable at 28 days. 24 of the 25 had undetectable HIV RNAs at day 28. And the one person who had detectable viral load, it was 160, and then a repeat viral load a few weeks later was again undetectable, and that participant had immediately reverted to daily dolutegravir at the end of the TB treatment. So we conclude from this study that dolutegravir trough concentrations with BID dolutegravir and 1-HP were actually, for much of the study, were higher than with standard daily dolutegravir. There was a decrease in the dolutegravir trough during the 1-HP period, probably indicative of dose-dependent induction of dolutegravir. All dolutegravir troughs remained above the dolutegravir target. No one experienced hypersensitivity or serious AEs. And based on the collected PK, viral suppression, and safety data seen in this preliminary data, gave the researchers confidence to move on to the next stage of the study, which would be seeing what is the pharmacokinetics of daily dolutegravir, not BID, with the 1-HP regimen. But right now we have the confidence to be able to say that a 1-HP short course TB prevention regimen can be safely and effectively given with dolutegravir-based ART if dolutegravir dosing is increased to BID. And maybe, fingers crossed, we won't even have to do BID dosing. But this is really exciting because decreasing the length of TB treatment or TB preventive therapy is a huge advance in increasing the accessibility of TB preventive therapy. And now that dolutegravir really is the mainstay of ART worldwide, and particularly in places where TB is most prevalent, having more shorter options for TB preventive therapy to be given with dolutegravir is really critical. So my lightning round of TB topics are to briefly go over one study that was unfortunately a negative study, spoiler alert, looking at rosuvastatin as a potential host-directed therapy adjunct for TB treatment. So there's some in vivo and in vitro data that statins can have an effect on the host response to TB in conjunction with TB treatment that might shorten the time to TB culture conversion, which was the outcome used in this study. So this group randomized 137 individuals with drug-sensitive TB to receive either standard of care TB treatment or TB treatment plus rosuvastatin 10 milligrams daily. The time to culture conversion was exactly the same in both arms, so no benefit detected of rosuvastatin. Maybe a hint of a benefit in one pre-planned subgroup analysis, but it was not statistically significant. And overall, nothing in the study to suggest any benefit for HIV positive individuals. There were very few people with HIV included in the study. So that was something of a disappointment because host-directed therapies are a potential advance in accelerating even further shortening TB treatment or being provided as adjunctive TB treatment. And obviously it'd be really nice to have a already approved, safe, effective therapy like a statin to be that host-directed therapy. So stay tuned for the space to see what other potential host-directed therapies might be evaluated. The second lightning round brief abstract I'd like to call out, also in the sphere of TB prevention for people living with HIV, was an implementation science study done in Uganda looking at providing clinic managers with education and support to increase the number of people who were receiving TB preventive therapy. So Uganda had, in the last 2 years, had a big nationwide push to get everyone to increase the number of people who were starting IPT, isoniazid preventive therapy, along with ART. And there was a really significant jump in the number of people initiating IPT. And then COVID hit, and the initial jump started to fall off. So this was a randomized study randomizing some clinics to have the intervention of the clinic manager teaching, and some did not. The main effect of IPT initiation increase was really seen with the nationwide push, and that was across both arms. But after the push, both with COVID and interruptions with COVID and kind of an attenuation of the initial push effect, the investigators saw a clear difference in clinics that were sustaining high levels of IPT initiation compared to those that were not. And so there was some evidence that interventions like these, providing additional support to clinic managers, did have overall effects on prescribing and uptake of IPT. And then I also want to call out, if folks have a chance to go back and see any of the symposia or presentations, I want to call out Eric Nurnberger's and Susan Dorman's symposia presentations as incredibly high yield for summaries of the TB and TB HIV landscape. Eric Nurnberger talked about new TB drugs, new TB drug classes that are in the pipeline, which is somewhat optimistic. It's been a while since we had some good candidates in the pipeline, and also some really exciting, still very early stage, but very exciting options for long-acting formulations of TB drugs in development. So as we're starting to see more long-acting HIV medications available, it's pretty exciting to think that TB treatment might also be reduced in patient burden with the availability of injectable long-acting medications. And Susan Dorman reminded us that we are also making progress in the landscape of TB treatment with the reduction of standard 6-month therapy for drug-susceptible TB to 4 months in many cases, with 4 months of treatment being non-inferior, and recently published article that mild TB in children can be treated safely with just 4 months of therapy as well, instead of 6 months. And we also are seeing, as we saw with the dolutegravir study, we've got increasingly short prevention regimens and with increasing compatibility with antiretroviral regimens. So 3-HP and 1-HP are moving forward, and we should have some guideline recommendations for 1-HP to be used more coming soon. So all of that's very exciting. All right, moving from TB, taking a whirl into the COVID-19 universe. Obviously, COVID-19 has dramatically affected HIV care, not just affecting COVID illness and people living with HIV, but COVID lockdowns and COVID disruptions having a systematic effect on delivery of HIV care, both in this country and worldwide. A medical student, Maya Jackson Gibson, presented a really outstanding abstract looking at the interaction between COVID-19 and HIV on pregnancy and birth outcomes in Botswana. And so we've seen globally that there's been universally negative effects of COVID on birth outcomes. And we've seen, in general, more severe disease outcomes of COVID-19 in people living with HIV, but there's been very little on the intersection between these two infections in the vulnerable population of pregnant people and perinatal delivery. So this group looked at the ongoing TSPAMO study of birth outcomes in Botswana. This is the study also in which dolutegravir outcomes have been studied. They also presented at this conference more conclusive data that dolutegravir is in fact safe and effective during pregnancy and should remain a first-line option. But they also had data from this study looking at women during the September 2020 to November 2021 period, able to look at women who had both a known HIV status and had a COVID screening test around the time of delivery up to 2 weeks earlier within 3 days of delivery. And they found 144 women had both HIV and COVID, 392 had COVID without HIV, and then there were another large fraction of women who had HIV and not COVID. They did note that epidemiologically, women living with HIV were more likely to test COVID positive at delivery than women without HIV. So they found, in terms of maternal outcomes, that maternal deaths were significantly higher in COVID. So looking at the COVID positive arm, 4% maternal death in the COVID positive arm, which is really dramatically elevated, and 0.1% in the COVID negative arm. The increased maternal death seen in COVID was not different by HIV status. And they also noted that the Delta variant was also associated with much higher rates of maternal death. One other thing to note is that the investigators did not have COVID-19 vaccination status available, but during the study period, less than 15% of people in Botswana had been fully vaccinated. So the assumption is the majority of people had not, in fact, been vaccinated. Moving to the birth outcomes, there was a 5.5% of risk of stillbirth in infants born to mothers with COVID-19. And then this forest plot shows both any adverse birth outcomes, severe adverse birth outcomes, and then select specific adverse birth outcomes, comparing HIV alone, HIV and COVID, and the middle orange category is HIV negative, COVID positive mothers. With the gray line, the one line is the reference line, HIV negative, COVID negative. So we can see that COVID and the combination of COVID and HIV had dramatically elevated risk for any adverse birth outcome and any severe adverse birth outcome. Stillbirth in particular, COVID-19 had on its own a slightly increased risk of mortality, but the combination, this was largely driven by the combination of HIV and COVID together, was substantially higher than HIV alone or COVID alone. So really showing the combination effect of COVID and HIV in this vulnerable population in Botswana. Further motivation to increase and encourage vaccination and prevention of COVID in people living with HIV. A few, what I thought were really important abstracts that looked at the intersection of COVID and HIV in other contexts. So there was a poster that looked at COVID outcomes among people who were hospitalized with COVID in Sweden. And they looked at the entire national registry of all people hospitalized with COVID. So we're able to compare outcomes in people living with HIV and people not living with HIV. And what they found was that there was no increased risk of worse COVID outcomes in hospitalization among people with HIV compared to people without HIV. Notably, in Sweden, of the people with HIV hospitalized with COVID, 93% were virally suppressed. The median CD4 was 560. Overall, people with HIV were younger than people without HIV. And I think this provides, again, increasing evidence that HIV alone is not necessarily a risk factor. It's really the combination of HIV plus immune suppression that drives bad outcomes in COVID. So for people who are on ART, virally suppressed, in the Swedish cohort, more evidence that equivalent outcomes between people with and without HIV as long as HIV is well controlled. And complementary data to that, an abstract from Argentina looked at outcomes of 844 people with HIV who had COVID-19, of whom 85% were on ART, 68% virally suppressed. Overall in this group, 20% were hospitalized, and as you hopefully can see from the forest plot, the only significant risk factor associated with hospitalization was CD4 count. So there was a much lower odds of hospitalization among people living with HIV with CD4 greater than 500. Again, supporting this idea that it's not HIV alone that confers a dramatically elevated risk. It's really the immune suppression in untreated HIV. And then finally, a colleague in San Francisco presented a really nice paper looking at clinic-level virologic suppression of the Ward 86 HIV clinic in San Francisco pre- and post-COVID. And with this time series analysis looking at the proportion of clinic patients who are virally suppressed. We can see that pre-COVID, the proportion of viral suppression was about 83%. And then immediately after the beginning of the COVID pandemic, that percentage of viral suppression dropped pretty substantially with interruptions in care, potentially interruptions in access to ART. But with the implementation of pretty aggressive outreach and provision of housing supports and nutrition supports, the group in the clinic were able to show that in this urban public safety net HIV clinic, they were actually able to improve clinic level virologic suppression to nearly 90%, to higher than pre-COVID levels, and which again they attribute to really concerted outreach services. So showing that by responding to COVID and its potential to interrupt and anticipating those needs, able to achieve clinic level outcomes that were improved. A quick highlight of great workshop given by Maria Prins from the Netherlands, talking about hep C reinfection. So it was actually kind of great at this CROI conference that there was not a ton about hep C, I think largely because treatment is highly effective, it works really well, and we're doing a great job at getting hep C treatment to particularly to our co-infected patients, but to hep C mono-infected patients alone. That said, despite the successes of DAAs, there is still a long way to go before we're at levels of hep C elimination, and some of this is driven by hep C reinfection, particularly among MSM. And so she gave a really nice presentation of some risk factors for HCV reinfection, particularly among MSM, distinguishing between factors that are seen as risks in primary infection alone, risks that are seen more with reinfection, and so number of casual sex partners was found to be a risk factor for reinfection more so than primary alone. But all of the rest of the risk factors, receptive condomless anal intercourse, sharing of sex toys and other sex contact equipment, would be risk factors for both primary and reinfection. And then for people who inject drugs, sharing equipment for injection drug use remains a risk factor for primary and reinfection hep C. The recommendation for hep C reinfection is to treat quickly and achieve a second cure, and also recognizing that COVID, in addition to having an impact on HIV services and service delivery, has also had a hugely disruptive effect on harm reduction services, hep C treatment initiation and completion, and testing, screening for hep C. So good potential. We still have a ways to go, and these are some of the risks to have in mind to focus on screening for reinfection. Then there were two really nice studies looking at hep C HIV co-infected people. The first poster was, to me, really kind of thought stimulating. So this was a French cohort of people living with HIV who were virally suppressed. And they looked at people who did not have hep C and people who had hep C and were cured and achieved SVR with direct-acting antivirals, and then looked at mortality rates over 36 months after cure of hep C. And what they found, comparing the hep C HIV co-infected patients to the HIV hep C uninfected patients, was that there was actually a dramatically higher rate of mortality among people who had been cured of hep C. And this was seen primarily in the second 18 months after achievement of SVR. So this increased mortality was not driven in the first 18 months after SVR, but then in the second time period after that. And so this increased mortality was seen despite HIV suppression in both groups, viral load suppression in both groups, and some controlling and matching for HIV stage, transmission risk factor, gender, and BMI. And the next stage of the research is to see what factors are driving this difference in mortality. And it seems to be primarily malignancies, but also some cardiovascular mortality. So I think for me, the takeaway from this is that it is necessary but not sufficient to treat and cure hep C to provide the best care for our patients, but patients remain at an elevated risk of mortality from having had hep C, even if they're able to be cured. And so additional high attention to screening and surveillance is still remains necessary for these folks. And then one of our colleagues here at University of Washington, Jimmy Ma, had a poster looking at people with HIV in the CNIX cohort, which includes many patients in Madison Clinic at UW, but also 7 other cohorts of people living with HIV around the country, looking at hep C co-infection among people with HIV in the CNIX cohort, and finding that transgender women were more likely to have hep C than cisgender men and cisgender women. They were more likely to be hep C viremic than cisgender men, but once transgender women, once they were in care, did receive DAAs as readily, as quickly as cisgender people living with HIV. So the implication here is that there remain significant barriers to transgender women accessing care, but they will succeed with care equivalently once they have access to it. So a message to us to keep an eye on our multi-vulnerable patients for the many potential risk factors they may face for not just HIV, but hep C is an important part of co-management. I will stop there.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.